Okay, sir. Chinmay sir, you can start. We're live.
Yes.
Okay. Good afternoon. This is our fifth PG crash course and second for the hip region, because this is the most common long case given for the postgraduate students. The first hip course we had around 1,000 participants. So this is the second one. First, I appreciate and congratulate Dr. Sudhir Kapoor to be with us. He is very much connected with Bardhaman. He was the inspector of MCI in Bardhaman for increased sitting capacity. And I was with him as co-examiner and partner many times. And Dr. Kapoor, Rajiv is our student from Bardhaman. And Dr. Kusubu Chaudhary is there, and Dr. Masood from Bardhaman, from Bangladesh. So I welcome you all with us for this interesting PG class course. So hip case, actually, as already told, it is the most common, and most of the students out of almost 80% get the hip case. So we have threadbare discussion on the long case of hip, and I expect more questions from the PGTs and residents, which will be answered by our esteemed faculties, I expect. So with a few words, I conclude my honorable speech and hand over to Rajiv.
Thank you, sir. Dr. Pasupati is also joining. Yes. So this is our fifth PG course module. So I would like our secretary, Dr. Partho Sathi Sarkar, to say a few words.
Welcome all esteemed faculties in WBO PG crash course module 5, and it was on request of our PG student that we have to have another program on hip, and really it is our privilege to have with us our teacher, Dr. Professor Sudhir Kapoor sir. We have learned from him a lot in our PGC period, and it was also a courtesy of the Bardhaman PG course to our president Chinmay sir. He was also organizer of that Bardhaman PG course, and also I welcome Professor Pashupati Chaudhary from Nepal. It is our big privilege also to have him, and also Professor Muhammad Hassan Masood from Bangladesh. And I think WBO has taken the initiative to make this PG course not only in India, but it is also streamed all over the world, as well as in special emphasis on Bangladesh and Nepal. It is all the credit that Rajiv Raman has coordinated Bangladesh and Nepal. So we are very much also lucky to have with us our scientific chairman and National Committee chairman, Dr. Rajiv Raman, and also our moderators, Dr. Anup Karmakar. He is mainly he is working behind the scene with all technical support, and also Dr. Sabbasi Satra, our treasurer. He is also working hard in this difficult time, and Moinak Chandra is the excellent and fantastic moderator. And also, I think after program, Dr. Devdatta Chatterjee will also join, but due to some reason, I think he has not been able to join till now. And now I hand over to start this webinar to Dr. Rajiv Raman.
Yeah, so just I have a small faculty introduction slide here. So Partho, in between, call Devdatta sir and ask him to join.
Okay, sir. Okay.
So PG crash course 5, module 5, hip examination. We have very known faculty today, Professor Sudhir Kapoor. He has been teacher of not only generation, but secondary generation of orthopedic surgeons, third generation orthopedic surgeons like us. And he needs no introduction, but I want to tell all peoples of the SARC country, they should know that he has been professor in Maulana Azad Medical College, which is one of the most prestigious educational institute in Delhi for 25 years. He was HOD of Lady Handi Medical College and director professor for 5 years. And he has been dean, and he established a department of orthopedics with postgraduate teaching in ESI Basidharapur for 8 years. He was past secretary and president of our beloved Indian Orthopedic Association. And he has written books on clinical examination of spine and hip, and those are very appreciable by postgraduate residents in India and in SARC country. Thank you, sir, for being here. Professor Devdatta Chatterjee He is past secretary of West Bengal Orthopedic Association, professor in the head department of orthopedics, Bardhaman Medical College. And after Chinmay Dasar, he is running the post PG course successfully in Bardhaman. Professor Pasupati Chaudhary he needs no introduction. He is a head and director of PP Kodala Institute of Health Science, Dharan. It is an autonomous institute and one of the best autonomous institute and in Nepal. And he is having postgraduate seats in orthopedics also. And they have the one of the best training facility in orthopedics in Nepal. And the whole institute has initially got support from India also, and a lot of faculty from India has worked there as a teacher, as a mentor. And Professor Pasupati Chaudhary is involved in lots of academic activity. Whenever there is a joint academic activity between India and Nepal, never says no. Professor Hassan Masood, a known arthroscopy surgeon, arthroplasty surgeon from Bangladesh, needs no introduction. He was in Nittor, one of the largest orthopedic hospital, has 1,000 bed. I have been to that hospital for doing some workshop also. This is the Asia world largest orthopedic hospital. And now he is professor in the head department of orthopedics of one of the very prestigious government medical college in Dhaka, Sir Saimullah Medical College. So this is the introduction of the faculty. And now I would like to invite Professor Sudhir Kapoor sir to start his presentation on hip examination.
Am I audible?
Yes, sir.
Okay, then I'll start. Well, I must thank West Bengal Orthopedic Association for giving me this chance to talk to postgraduates not only from India but in Bangladesh and Nepal also. I hope they would gain definitely something once my talk is over. Well, as been told to you, I mean, I'm talking of postgraduates now. I'm talking to them. As they know that hip examination, they will get mostly a long case, either a hip or a spine. This is the usual trend. And in the further practice also, they will need some knowledge regarding the examination of the hip joint. Well, just a few peculiarities. We know that it is a joint which has got it is a ball and socket type of joint with extremely good mobility. And besides mobility, it transmits the body weight also. If the hip joint is affected, the patient's locomotion is affected quite early. Then there are a few peculiarities in the sense that there is a neck shaft angle of about 120 to 135 feet, for neck ventilation of about 50 or so. And the acetabulum is also at an anteversion of 15 to 20 degrees. Now these are few anatomical bases for few tests, for few understanding of the hip joint examination. I will not spend much time on history, but basically these are the presenting features are in front of you. They may be pain, swelling, deformity, limb length discrepancy, and reduced mobility in a from the patient about the ability to squat normally and squat cross-legged. This is one of the earliest complaints, and unless you ask the patient very, very specifically, he may miss it. So the postgraduates just make it a point to ask about any difficulty in squatting. Besides all the things,
Your PPT, sir, please share your screen, sir. Your screen is not shared, I think. Screen. Share your screen, sir.
I had shared it. Let me check it once again.
Yeah. Just share it, sir. You will see it's open. Click, then downward it will come share, sir.
I've done that already. Okay. And whatever I said till now was not heard?
It was heard, sir, but it's not coming on the screen.
It was not visible.
Your PPT.
Okay, fine. Now is it visible now?
No, sir, it's not sharing.
So you need to click the share screen, then select your PPT window.
I've already done.
Yes. Now it's coming.
Now it's there.
Okay, fine. Sorry.
Yes, sir. Now it's there.
I'll go. This is one of the common long cases in the exams. And hip, as told you already, I'm just repeating it for the sake of people to understand that there are a few peculiarities to the hip joint besides being a very mobile joint, it also transmits the body weight. And if there is affection of the hip joint, then the mobility of the patient is affected very early. Then a few peculiar things about the hip joint are, there is a neck shaft angle between the femoral head and the neck of about 120 degree. Then femoral neck is in an anteversion, which I'll come to this later also. The anteversion is in the range of about 15 degrees or so. And then acetabulum is also an anteversion of about 15 to 20 degrees. Now, these anatomical points help us to understand few clinical signs, which I'll be describing later. These are the important points which a patient will, important complaints a patient would have if he has got a hip joint disease, pain, swelling, deformity, limb length discrepancy, and reduced mobility. Now, one thing which is very, very important for our countries, I'm talking of India and the neighboring countries, that the patient would have difficulty in sitting, squatting in the normal way and squatting for a cross-leg squatting. These things patient may miss, but the examinee should make it a point to ask the patient very, very specifically, does he have any difficulty in squatting normally and squatting cross-legged? And if the examinee should not miss this point in the exam. But this is very, very relevant for our countries. I will not spend much time on the history taking, because basically this class is on examination. Now, all the teachers have been telling regarding that the clinical examination should be thorough. As far as I am concerned, I always stress in my classes that the postgraduates must follow a sequence. If you follow a sequence in your formative years during your training, you will not miss any point in the final exam. So as far as I am concerned, sequence is the most important thing, and you must start with a particular sequence and follow that sequence throughout your training and further career also. Now, the suggested sequence of the hip examination would be inspection, which would include gait, attitude, and the local inspection, palpation, and deformities and palpation go side by side. So inspection, palpation and deformities, movements, measurements, and few special tests. This sequence must be followed. And again, all of these broad headings, they have got a further subsequence. Now, I've told you already that the inspection would include gait of the patient, attitude of the limb, and inspection in general. So let us start with the gait. Simply speaking, gait is a manner of walking. While if you define it further, it may be defined as a rhythmic, repeated sequential movements of the lower limb that advances the body, that is center of gravity, forward in the desired line of progression while maintaining a stable body weight posture and optimally conserving energy. This is the exact language, but simply speaking, gait is a manner of walking. Now, there are a few pathological gaits which would be the frequent pathological gaits which we are likely to encounter during a hip examination are antalgic gait, short limb gait, a Trendelenburg gait, stiff hip gait. Infrequently, we may find these four gaits form the either single or in combination. Many times, a patient will have antalgic gait, or a patient would have a short limb gait plus Trendelenburg gait. So these are the four major gait patterns which a hip joint patient would have. Infrequently, there would be hip hiking or circumflexion gait, which is almost similar to stiff hip gait. Then posterior trunk bending gait and scissoring gait, which I don't discuss in details. But the first four gait patterns I will discuss in detail and show you examples also. This example of antalgic gait, the basic hallmark of this gait is that the patient has got a pain on the affected side. He wants to take off the weight almost immediately from the affected side. So the stance phase is reduced. So the stance phase is grossly reduced and patient may grimace. Patient face may show that there is pain while he is putting weight on that limb. Please see this example. Patient has got a right hip which is painful. He wants to take the weight immediately off the right limb. So very short. And once he bears the weight on the limb, his face shows that he has got pain. I'll show you one more example of a painful gait. Now this patient is one more example of an antalgic pain. The patient has got a affected right side. And one more thing you would find that besides grimacing, a patient has got increased movements of the upper extremities as if he's trying to propel the body forward. The typical example of antalgic gait. The next gait is Trendelenburg gait. Trendelenburg gait, as all of you know, that it is dependent upon that there is some defect in the abductor mechanism. If just to tell you something about the anatomy, which is important to understand this gait, and the Trendelenburg test also, that intact abductors of right side ensure that the patient's hemipelvis does not fall on the left side when the patient is standing on the right side. I'll again repeat. Abductor mechanism of the right side ensures that when the patient is standing or in stance phase on the right side, left side hemipelvis does not go down because of gravity. So right abductor mechanism is working on the left hip. Please understand this point. Otherwise you will not be able to grasp the basic pathology of Trendelenburg gait. Now, please see this patient. Patient has got a abductor mechanism affected on the right side. Once he puts weight on the right side, the left hemipelvis attempts to go down. To prevent that going down of left hemipelvis, the patient trunk bends on the right side. And if the patient has got a bilateral abductor mechanism weakness, if the abductor mechanism is weak on both the sides, the patient's trunk bends alternately on both the sides. The patient will have a waddling gait or duck gait, like in this patient. This patient has bilateral, I think, the old dislocation of the hip, CDH. He alternately bends on the two sides. When he's putting weight on the right side, the trunk is bending on the right side. When he's putting weight on the left side, trunk is bending on the left side. So this is a bilateral Trendelenburg gait. Now short limb gait. If the patient has got a short limb, the trunk tends to go up and down on that side. Please understand that in Trendelenburg gait, the trunk lurches on one side. In short limb gait, the trunk goes up and down. This patient has a combined short limb gait and a Trendelenburg gait, which is very often a patient who has got a short limb because of hip disease would have a combination of short limb as well as Trendelenburg gait. The Trendelenburg gait tends to get masked by short limb. So you must compensate for the shortening of the limb to show the exact amount of Trendelenburg gait. Now please see this gait, patient's gait. Short limb gait on the right side. Now you must examine this patient with the compensated shortening. He has been given a shoe ring on the right side. The Trendelenburg element gets more pronounced because the shortening has been compensated to a large extent. So a combination of short limb and Trendelenburg gait. Now the fourth common gait which we encounter in hip joint disease is the stiff hip gait. When because of the disease the hip joint becomes stiff, the normal rhythmic movements of the hip joint and the pelvis on that side become absent. It seems as if the hemipelvis and the thigh, because of the fused hip, are moving in one segment, as if there is one bone going from pelvis to the hip side. Now, see in this patient. He has got a stiff hip gait on the left side. As the patient turns, you can see that the hemipelvis and the thigh move in one segment. At this I'll show you one more example of stiff hip gait. This patient has got a stiff hip on the right side. So, besides I go further, all of you must understand that the gait should be examined only if the patient is able to walk and allowed to walk. Patient is able to walk and allowed to walk in a well-lit room in minimum appropriate clothes. Everything is important. Examine the gait only if the patient is able to walk and allowed to walk. If the patient has got an acute painful condition, don't make him walk. So, if the examine in a well-lit room in minimum appropriate clothes and observe the patient for about 10, 15 or 20 steps going towards you and going away from you, like I have shown you in my videos. All these points are important. This was about the gait. Now this Trendelenburg test, many people include this in the special test, but since you are examining the patient while the patient is still standing, it is a good policy to examine to do the Trendelenburg test now. Now, I have told you already, if you remember, abductor mechanism of the right hip controls the falling of hemipelvis on the left side when the patient is standing on the right side. First, I will show you a normal situation. Then I will show you a Trendelenburg gait. This patient has got a normal abductor mechanism. When he stands on the left side, the right side hemipelvis is not going down. Rather, the right posterior spherical spine goes a little up. This is a normal situation. Now let us see a patient who has got a Trendelenburg sign positive. Now this patient has got a disease side on the right hip. When the patient is standing on the right side, the left hemipelvis tends to go down. To prevent that going down to some extent, the patient bends the trunk on the same side. And if you see, the posterior spherical spine and the gluteal folds are down on this side, which should not have happened if everything was normal. I hope I'm very clear. Now let us see this point in a video. Always examine the Trendelenburg sign bomb behind with a patient who has been appropriately undressed, and first make the patient stand on the normal side and then on the disease side, preferably with the arms folded. Now please see the video. Ask the patient to turn around and you will observe the posterior spherical spine, gluteal fold and the shoulder. This is the normal side. Everything is normal. Right hemipelvis is not falling down. As the patient stands on the right side, the left hemipelvis goes down. Posterior spherical spine is down. Gluteal folds are down on the left side. I hope the things are clear now. Now there is something called assisted Trendelenburg test. If the patient is not able to stand on the affected side, the examiner may help him to stand. Please see this video, then I'll explain. Please see this video first. Patient has got a disease on the right side. First, standing on the normal side. This is done from front, not from back. The patient stands on the right side. You notice the patient's left hand. He is putting weight on the examiner's right hand to get support, putting extra pressure. The examiner will feel extra pressure on his palm. Now, that is a genesis of using a cane or a stick on the left side. This patient, because of a disease on the right side, will use a cane or stick on the left side. Please see this video once again. Standing on normal side. Now see the palms of the examiner and patient's left palm exerting pressure. This is called assisted Trendelenburg test. Hello. Hello.
Yes, sir. Yeah.
I hope everything is clear.
Yeah. Yes.
Okay. Okay. I'll go further.
Yes.
Now we have examined the gait and the Trendelenburg test. Now let us go to the attitude of the limb. The limb, the position in which the limb is lying, it will give you an idea about the deformity which the patient is having. Extension is you can read it out. I'll not repeat them. The deformities or the attitude can occur in combination. Flexion, abduction, and external rotation are a common combination. Flexion, adduction, and internal rotation are another common combination. I hope nobody's ringing me up.
No.
Okay. Fine. Let us see the attitude of the limb. This is an example of a limb in external rotation. By noticing the attitude of the limb, you can say that this limb, because of the hip joint disease, is in external rotation, while this hip is in internal rotation. This is the typical attitude of flexion, adduction, and internal rotation seen in case of posterior dislocation of the right hip. Very clear. Now, we have seen the attitude. Now we'll come to the inspection of the patient, which should be done from the front, back, and the side, and lying down. I'll show you them one by one. This is the inspection from the inspection on standing from front. Notice all these points. The anterior spherical spine. The examinee should have marked these points. I'll not repeat them. Anterior spherical spine the most crucial, but mark these points also. Now, inspecting, I'm giving you an example of hip joint disease on the right side. Once inspecting, what are the findings, most usual findings by inspecting from the front? The head is central in this patient. Both shoulders are the same level. Right anterior spherical spine is at a lower level, and right patella is at a lower level. Examine the same patient from the side. Make a note of the lumbar lordosis, but is increased or not. This is because of the flexion deformity of the hip joint. And the right hip and the knee are flexed. You can make these points also. Similarly, inspection from standing from the back, you make a note of all these points and mark the posterior spherical spines and note about the gluteal folds and the gluteal bulk and the back of the thigh. Now, in this same patient, while examining from the back, the head is central, both scapulae are symmetrical, right posterior spherical spine is at a lower level, and lower lumbar spine has got a convexity towards the right side. Now, patient lying down in supine position, the right superior iliac spine, right anterior spherical spine remains at a lower level, and the right lower limb is in external rotation. Then you have to make a note of all the points when the patient is lying down and you are examining from the side. Make a note of the lumbar lordosis and mark anterior spherical spine and the iliac crest. Also mark the trochanter and see for the bulk of the and mark the thigh muscles. So in a summary of inspection, we have seen the gait, we have seen the attitude, we have examined the patient from front, from side and from back. Once you are inspecting, please make note of any redness, any scars, any sinuses, any muscle wasting, any ulcers, any operative scar. So all of these points must be inspected once you are inspecting the patients the way I have shown you earlier. After inspection, we go to palpation. These are the different points which are supposed to see on the palpation. Touch, to see for the temperature. Tenderness, I'll describe in detail in my further things. Then vascular sign of Narath may be examined during palpation and also feel for the trochanter. Also feel whether note down its size, shape, thickness, position and surface. All things are important for a examination of the trochanter. So we'll see them one by one. We'll just see the touch. You can always feel with the back of the hand to see whether there is any local rise of temperature or not. Let us come to tenderness. Now, anterior hip joint tenderness is about 1 centimeter below and lateral to the femoral artery, which is almost at the midpoint of the inguinal ligament, lying midway between the pubic tubercle and the anterior superior iliac spine. This is the point to feel for the hip joint tenderness. There's another way of eliciting hip joint tenderness. That is a pelvic compression test. Particularly positive if the disease only is central and the disease is not extended to the periphery. So bilateral pressing on the two trochanters may elicit tenderness. Now, if there is a diseased structure in the vicinity of the hip joint, these are the other common sites of tenderness. The examiner should be aware of these points. Origin of erector longus, insertion of iliopsoas, ischial tuberosity, and trochanteric area. These are the other common points of tenderness, but basically we are concerned with the anterior hip joint tenderness and bilateral pelvic tenderness. You must palpate the iliac fossa. You may find a cold abscess, or if the patient has got a protusio acetabular and the patient is reasonably thin, one may be able to palpate the acetabulum from the inside.